Welcome to the Dr. Kumar Discovery Podcast. My name is Dr. Ravi Kumar. Today, we're talking about something that touches every single chronic disease that you can think of, metabolic health. My guest today is Dr. Vyvyane Loh. She's a physician who has spent her career at the intersection of metabolic medicine, muscle biology, and human performance. And I have to tell you, this conversation genuinely surprised me. We covered things that I hadn't even heard of before. So believe me, you're in for a special treat today. By the end of this episode, you're going to understand why muscle is the most underappreciated organ in your body and what happens when you lose it. You're going to learn why 80% of chronic diseases are actually reversible and why your doctor probably has never told you any of this. And we get into GLP-1 drugs, where Dr. Loh talks about what these drugs are actually doing to your immune system and your brown fat. This is stuff you're not going to hear anywhere else, folks. Honestly, it's going to be a real eye-opener. It was for me. But before we get into it, a quick disclaimer. Dr. Loh and I are both physicians, but we're not your doctors. This podcast is for informational purposes only. Our goal is to give you real knowledge backed by real science so that you can have a better, more informed conversation with your own healthcare provider and ultimately take greater ownership of your own health. Also, this podcast is completely separate from my role as assistant professor at UNC. All right, let's get into it. My name is Dr. Ravi Kumar. I'm a neurosurgeon in search of the causes of human illness and the solutions that help us heal and thrive. I want you to join me on a journey of discovery as I turn over every stone in search of the roots of disease and the mysteries of our resilience. The human body is a mysterious and miraculous machine with an amazing ability to self-heal. Let us question everything and discover our true potentials. Welcome to the Dr. Kumar Discovery. Dr. Loh, thanks so much for joining us today. We hear a lot about metabolic health and how it might be the center of all chronic disease. Can you tell us what metabolic health is and how you look at it in regards to human health and wellness?
I guess the best place to start, Dr. Kumar, is I like to define what metabolism is for most of my patients first. Because, metabolic health obviously is circling around metabolism. And what exactly is metabolism? And I think the best way to think about it is that it is the energy management system in your body. Okay, how we regulate and manage energy. And why is that important? Because if we want to be alive, we need energy. That's the basis of everything. And if we mismanage the energy and we have mismatches in our energy demands and what we can supply, then we're going to have disastrous consequences in different parts of the body. So for example, the brain has a very heavy energy demand. Right? It's a tiny organ, maybe 2 pounds, a little bit more in some people, but it's going to easily take up 20% of your total energy intake. And if you're stressed, it may go as high as 25%. And in the developing brain in young children, it may be as high as 30%. Okay, so it's consuming a lot of energy. But if there's a drop in the energy supply to the brain, then obviously misfunction is going to happen. We're going to have the brain rerouting, supply to different areas, the survival areas, and maybe other areas are not as well prioritized. So that's just the brain, but it happens in any other organ in the body. So metabolic health really is this system in our body that manages and regulates energy flow. And if there's a mismatch, it should be able to adapt. But over time, if we chronically burden it through our environment, through maybe our nutrition, our sleep patterns, and so forth, there comes a point where it really can't keep up with the mismatch. And that's where we start to see dysfunction happening. And that's when we notice the symptoms and people start getting sick.
Yeah. Okay. So what does metabolic disease look like clinically? If you have a patient with metabolic disease, what are they experiencing?
So the classic metabolic disease you could think about is, let's say, diabetes, right? High blood pressure, also another metabolic disease. And along with that goes kidney failure and heart disease. So a lot of times it's termed cardiometabolic health. And the general common symptoms are that people start feeling unwell. Fatigue is a big one. Brain fog, again, because when there is some issue with energy management in your body, then obviously your brain suffers because a lot of times it doesn't get what it needs. So brain fog is very common as well. And then depending on different organ systems, if your kidney is experiencing more of that stress, then you might end up with kidney disease, right? If let's say your heart is experiencing that stress, then you have more cardiovascular disease. And if your brain is having more of that, then we might go into the neurodegenerative diseases and so on.
So metabolic disease is this poor utilization of energy, essentially in all the cells. And you highlighted all these diseases that basically are manifestations of metabolic disease.
Yeah.
I would say that there's really no tissue in your body that's not touched by metabolic insufficiency or metabolic disease.
100%.
Yeah.
You know, everything needs energy to survive, right? And there's not
Yeah.
one cell in your body that is exempt from that rule.
Right. So what causes it? Why do we develop metabolic disease? Why don't we just live like we're supposed to and operate like we're supposed to?
I think our bodies, human species, developed under certain environmental conditions, and those conditions have changed rapidly, right? Compared to the evolutionary scale, it's changed to a much quicker extent than our bodies can actually adapt. And so now there's a mismatch between what we're built for and what the environment is around us. Now, what do we do when there's a mismatch? You would think that we would try to make the environment fit our bodies, but our solution seems to be, let us force our bodies to fit the environment. Okay, we'll force it one way or the other. Either you white knuckle it through or we'll put drugs on board. We'll do something to force your body to fit the environment. And when we talk about making the environment fit us, well, nobody's that interested. Yeah, whatever. Right? So it's kind of a weird way to think about it. And for me, it doesn't seem like the most useful or helpful way to think about it. But I feel like that's how it is, especially in the medical system that we inherit.
Yeah. Yeah. This whole concept of evolutionary mismatch is really fascinating to me because, like you said, there are these ancestral conditions or evolutionary conditions that our biology literally took millions of years
That's right.
to synchronize itself with, to live in harmony in that specific set of environmental factors like nutrition, sunlight,
Yes.
sleep, all these things that we were designed to do. And now we have this different environment and we are trying to take, million-year-old evolutionary biology and fit it into something that's relatively new,
right,
as far as nutrition and environmental stressors and all that. So tell me what these specific mismatches are that are causing metabolic disease.
A big one is nutrition, obviously, right? Because we need faster, we need more convenient, we need things that will stay on the shelf longer. And so we have a lot of processed foods, for example. And of course, cost comes into it as well. Sadly, sometimes getting real foods is more expensive than the highly processed foods. So depending on where you're living, sometimes a mother may be able to afford a bag of chips better than eggs, or dairy or any real protein, for example, for their kids.
Yeah.
So nutrition is one piece. Another piece is movement or lack of movement, because now you don't have to move. Maybe you just move your little finger, tapping on the keyboard, right? A nod here and there, right? Put on your headphones. That's like a whole workout. You don't even need to go to work if you're, working remotely, right? You don't even have to walk to your car now. You can get things delivered to your door. So we were designed to move, really designed to move. And the brain is designed for movement. And brain health is really dependent on how well and how much we move, right? And the minute we start, cutting down on movement is when our brain health also starts to suffer. My father passed away a few years ago, but I knew he was getting into trouble when I saw that he became more and more sedentary. So he used to be very active. He used to go for long walks and so on. Then in the last 2 years of his life, he just basically sat in front of a screen all day. He hardly walked. And I told my brothers at that point in time, try to get him to move more because he's going to decline in terms of cognition. And that's exactly what happened. mean, his cognition really dropped significantly as he just became more and more sedentary. So I think those things are linked. And then, within the 2 years, he was gone. So I did expect it. I could see it coming.
I always tell my patients, as soon as you stop moving, you start dying.
Yeah.
It doesn't matter
Yes.
what age you are.
Yeah.
Even after surgery, I do a lot of spine and brain surgeries. I want my patients up and walking immediately after surgery, if it's possible.
Yep.
Because if they do that, their whole biology lines up and they heal better.
Yes.
If they don't move, they get pneumonias. They get atelectasis of their lungs, where the lungs kind of just close down. They get blood clots in their legs. They get urinary tract infections. Their wounds just don't heal. I mean, you would think, the intuitive thought would be, oh, if you move around, you're putting stress on that wound and it's going to come apart.
The body
it's the opposite.
needs to detect that stress, and then it knows how to heal properly. It knows up from down. It can lay down tissue and the collagen in an organized manner, and that depends on you moving. You're absolutely right. Yeah, it's fascinating, isn't it?
Yeah, it's totally fascinating. And so I think movement is essential to life for this species that we are, humans, because we are a species that move around since the beginning of time. So tell us how maybe that is linked to muscle and how muscle is linked to metabolic health, because I think this is something you talk a lot about.
Yeah. So obviously, people realize that whatever you do, you need muscles, right? You need to have that musculature to be able to support you doing anything, getting out of bed, making your bed, going to work, shopping, and so forth. And as we age, we tend to lose muscle and we tend to become less and less active, right? What happens is over time, if we're not being aware of this and actively trying to mitigate that, you lose more and more muscle. Now, muscle is your biggest glucose sink in the body. And this is something I wish people would talk about more, because 75% of the glucose in your bloodstream would be taken up by muscle. Now, imagine you have, let's say, a huge, dumpster, okay? A big dumpster size to contain the glucose. And you can just dump the glucose into that dumpster. But over time, the dumpster gets smaller and smaller. And just to make it more dramatic, imagine now, instead of the dumpster, you have a trash can, a tiny little trash can, and you're supposed to fit that same volume of glucose into the trash can. It's not gonna fit. And what will happen is the trash or the glucose is gonna spill out. And spill out where? Into your bloodstream. Right? So in terms of your metabolic health, that muscle is the biggest container for that glucose. And we need it to go in there, feed the muscle. It may even be stored in a safe form so that the muscle can use it when necessary. And so in that sense, it would be stored as glycogen. But you can't have this vast volume of glucose floating around in the bloodstream without causing damage, because glucose is very toxic. And if you're not careful, as your muscle mass shrinks with age, then you're losing that natural reservoir that you have. And that is like a very dramatic change. So people will often say, Dr. Loh, I'm not doing anything different. I'm eating exactly the same, right? The weight may stay the same. And that might be because you're gaining more, you have more fat and you have less muscle. So if you look on the scale, if you lose 5 pounds of muscle and you put on 5 pounds of fat, congratulations, you're the same weight. And that's what a lot of times, you go to your medical practitioner and that's what they measure. They measure your weight and they measure your BMI, but they never think about your body composition. So one time, tell the story because it's particularly frustrating for me. I was at a cardiometabolic conference, right? And the presenter got up there and she told this story. She's an endocrinologist, and she told the story about how at the age of 60 something, she got diabetes, but it's not type 2 diabetes. And she called it autoimmune diabetes. Now, she also pointed out that all the antibodies were negative. The workup was negative for any autoimmune diabetes. And so she labeled it this new unknown autoimmune diabetes. She also pointed out that she knew for a fact it wasn't regular type 2 diabetes, because she says, I'm actually underweight. Okay, she made that a point. She says, most people with diabetes have obesity or are overweight, but I'm not like that. And therefore, I am different because I am underweight. And her BMI, she shared, was actually under 19. Okay. And just looking on the screen, she looked frail. And I was thinking to myself, before we go to a new mysterious autoimmune type of diabetes, and she might well be right. I'm not saying she's wrong, but before we jump there, I'd like to know what her muscle mass is. And I would have liked to see a trend and see her blood sugars go up as her muscle mass shrank. You know what I'm saying? But we don't track those things. So I guess we'll never know.
Yeah, that's something I commonly see is people who you wouldn't look at and say you're overweight or you're obese, but you look at them and you see that their muscle mass is not good.
Yeah.
They are just soft in general.
Yes.
And they often have type 2 diabetes.
Yep.
Because they don't have, like you talked about, this sink for glucose.
Yes.
They don't have this energy consumptive organ all over their body, which is muscle, basically absorbing the excess glucose that happens after eating processed food or even, healthy foods. And so they're basically having high levels of glucose floating through their bloodstream much of the time, causing all these complications that diabetes is known for, and they don't look obese.
That's right. And one other thing I always like to point out to my patients is just because you can see the muscle or see the muscle definition does not mean you have a lot of muscle. So, for example, I had a patient and he had, inflammatory bowel disease, and you can see his muscle definition very clearly. You can see the 6-pack or 8-pack or whatever, right? It looks very impressive. But when you look at the DEXA and look at the body composition, he's in the bottom 1 percentile, so he has very low mass for people in his demographic, right? The point is that if you look at it, you think, I can see the muscle. And that's because he also has very little fat. So we've removed the fat so you can visually see the muscle. Doesn't mean you have enough muscle. So that's a common mistake because people go, but look at him, her, whatever. You look at the 6-pack. That just means we took away the overlying fat under the skin and you can now see the muscle. Doesn't mean that person has enough muscle. And to your point, that person might still be very frail and could still be at risk for developing, diabetes or insulin resistance.
That's very interesting. And I think this is like a good point to start talking about your approach to metabolic disease. Because if someone in the audience has metabolic disease or one of their family members has metabolic disease, they'll go to the doctor and they'll get a prescription for metformin or they'll get put on a GLP-1 agonist. And that's the treatment, essentially.
Yeah, that's right.
What do you think about that?
So that's not my approach. Obviously, I think you and I, we share a lot of the same way of thinking about health. 80% of chronic diseases are really reversible, okay? But we never talk about that. And we just, when someone goes to see their doctor with new onset diabetes or high blood pressure, they just hear it's genetic or it's because you're aging. Yeah, that's usually the most common things that the patient will report back to me. And there's never any talk about what you might be doing to make your blood sugar go out of control or your blood pressure and so forth, right? So my approach is that when I see a patient, my aim is to help reverse the disease because I know that 80% of chronic diseases are reversible. So when I see a patient, that's my goal for the patient, right? Is to try and reverse it. What the current medical industry does is manage disease. Okay, I'm going to tell this story. I had an old house. I still have that old house in the Boston area. There's a lot, it's made of wood and so forth. One year, there was termites around it. So I got all these quotes from different termite companies, right? But if you look at the contract, doesn't matter which termite company, they quote you a price and the contract says they're going to manage the termites. They're not going to remove the termites, God forbid, right? Let's just manage the termites because then next year we still continue to manage the termites, right? So this is our approach in medicine. We don't want to get rid or reverse the disease. There's no focus on that. We never even talk about that, okay? The aim is to manage it. Now think of all the medications we have. with the exception of antibiotics. All medications are to manage symptoms. They're not to reverse the disease. Antibiotics, you take it, you kill the bug, done. Okay? Okay, you could call it curative. But almost everything else is to manage the disease, kick the can down the road, kick it down the road. Now we need more drugs to manage. Now we need that drug for the side effects of this drug. And then, it keeps rolling down the hill, right? And now we have an avalanche at the bottom. So that's the general approach. And that's not my approach. So when I first see a patient, my approach is, okay, let's talk about how we can reverse it as much as we can. And sometimes there's already damage to the organs, but by and large, there's still so much that we can do because you and I just talked about this, how wonderful the body is and just how amazing it is in terms of regeneration and repair. We just never give it a chance, right? So to this day, I still have doctors telling their patients, you have liver fibrosis and we can't reverse that. That is not true. The data is very clear that you can reverse liver fibrosis. Okay. And in some cases, even cirrhosis, though that is much harder and it's iffy. Plus minus, with cirrhosis. But with fibrosis, yes, you can. But we never tell people that. We never even tell them that fatty liver, which is an even earlier stage, we never even tell them that fatty liver is reversible. Okay? So if we start there and you have a patient and they're diagnosed with metabolic fatty liver disease and you say, well, it's your genetics, aging, there's nothing we can do. We'll just watch it. We'll just watch you get sicker and sicker and sicker. That's not my approach. My approach is immediately thinking about, let's talk about how we can reverse this as much as possible. Okay. The basics have to be in place. And the basics, no one wants to hear this. The basics are your nutrition, right? Your movement, exercise, movement, sleep, and how you handle stress. All of that is basic. No one wants to hear it. Now, I always say, Dr. Kumar, that our full-time jobs as physicians, our full-time job is to tell people things they don't want to hear. That's the full-time job, right? But then the job is to present it in a way that it's safe for them to hear. They don't feel judged and they can hear it. And then after they've heard it, to give them a plan. And I always said to my patients, and they know this, I said, I can be tough. I'm never mean. Here's why. Because when I bring something to you, there's always something you can do about it. Because telling you something and not giving you a way to do something about it, that's kind of mean, right? Because it's causing a lot of stress and anxiety. And that's not my goal. My goal is to give the news and to have a plan, right? And it's not 100% that we can reverse everything, but there's a lot we can still do. And we never talk about that enough, I feel.
Yeah, I mean, the body is this amazing machine that wants to heal.
Yes.
If you get out of its way.
That's right.
Honestly. And most of the time we're getting in its way with poor eating, no exercise, smoking. There's a number of things that you do, not getting enough sleep. Just those things hurt you. And the body is trying to heal, but you're blocking it. So what happens? And if you optimize nutrition and you optimize sleep and exercise, what happens to these chronic diseases that are related to metabolic syndrome?
So I will say that in all my years of treating patients, I have taken most people off their insulin and their diabetic drugs. And even their primary cares are shocked. They're like, oh, I never thought you could take a patient off insulin. I've never seen that happen, right? And I'm like, yeah, we're really good at prescribing. We're never really taught to de-prescribe. I even taught a course on de-prescribing once, just because, we don't talk about that. But I have seen their diseases reverse so that their blood sugars normalize. They are off their medications. Their lab tests normalize, and they feel so much better. They can function better. They feel good about themselves. And a lot of times they get discharged by their specialist. So the kidney doctor will say, I don't need to see you anymore. The endocrinologist will say, I guess I don't need to see you anymore. And that's the best news for me.
That is great. I think most people know that diet and lifestyle is curative in most of these conditions. Even if your doctor isn't tell you. It's common sense that if you're healthier, if you feel better, if you're moving and you're eating well, you're going to be a better person and optimize your health and wellness. But saying that is much easier than actually doing it. How do you get your patients to accomplish these goals through diet and lifestyle? Hey guys, I need a quick favor. If you're getting value from this show, would you please take 30 seconds to rate and review us on Apple Podcasts? I know it seems like nothing, but it genuinely changes how many people the algorithm puts this show in front of. And if an episode hits home for you, send it to someone who you think needs to hear it. I'm doing this to cut through the noise and bring you clear, honest information on health topics that actually matter to all of us. So please help me get this show to more people who need it. Cheers.
There are a couple of issues there, right? We know generally that lifestyle modification can do most of the heavy lifting in our health. However, a lot of the information on what is a healthy lifestyle may not be actually good evidence-based information, right? And it's just what has been regurgitated over the ages, and it's very culturally dependent as well. So one example I will give you is this Mediterranean diet. Every dietitian you go to, every doctor that you go to usually will say, oh, you should be on a heart healthy, low-fat Mediterranean diet. Now, when I ask for actual criteria for that, nobody tells you because they don't know. We have never quantified what that is. So now when I say Mediterranean diet, in my head, I'm thinking one thing. In your head, you're thinking something else. Someone's thinking Greek salad, right? Someone is thinking, sausages. All of it is valid because Mediterranean is a huge area, a huge region, right? We've never really quantified it. In addition, pretty much across the board, if you look at the culinary habits across the Mediterranean, at the very least, they are moderate fat and in some cases, high fat diets. So a low fat Mediterranean diet is an oxymoron, does not exist. Okay, maybe in a separate universe that I am not inhabiting. But whenever people go, a low-fat Mediterranean diet, I'm like, okay, I'm having a hard time already. So imagine what the patient is going through, right? So we have such poor criteria and we have such poor evidence for these recommendations that we just dole out. I'll give you another example. So, you know that if you have diarrhea, brat diet, and also one of the things you should have is apple or banana. Yeah. And the reason is that the pectin in these fruits, the pectin is what helps bind you. Okay. But actually, if we're accurate about it and we are precise and you really want to help the patient, it's a green banana and a green apple. Because as the fruit ripens, the pectin is converted to sugar. Mm-hmm. And you pretty much have no pectin left, okay? But what do we tell patients? Have banana, have apple, okay? And what do? We go to the supermarket, we buy the juiciest, reddest apple, right? Or the bananas that are ripe, because who wants to eat a green banana? No one, right? But again, we never think about that. We just say, oh yeah, just have a banana, have an apple, right? Mm-hmm. So yes, we can talk about nutrition and lifestyle modification, but across the board, there's not a lot of good evidence. And many times the advice that's given, even in medical circles, is not evidence-based or imprecise, to say the least, okay? So that's one category. And then even with good evidence, how do we make it happen? And you're absolutely right. How do you help the patient? Now, I always say that, we can make the plan. We can communicate the plan. The only person that can do anything about the plan is the patient. And that person has the least support and, resources. Okay? We just kind of deliver the plan and good luck, wish you well, right? Godspeed, right? So I find that working with coaches, having a lot of accountability, making sure that you have a frequent check-ins. So, I had a practice that focused on obesity medicine. And when someone was struggling with their weight, I never had them follow up in 3 months. 3 months! That's a whole lifetime. A lot can go very wrong. I tried to see them within the next week, or within 2 weeks. At very least, phone call. at the very least, you need to check in way sooner, way more often. You can't let people drift for 3 months on their own and then they come back and you go, oh, how come you didn't do it? That's just not how it works, right? It's not going to be helpful. So I think the close supervision, the coaching aspect, the accountability is very, very helpful. And then giving the right instructions in a granular way. So I'm very precise. I do not tell people go eat protein. I tell them how much. I want them to schedule it. So when I prescribe nutrition to my patients, it's like writing a prescription. There is a dose, there's the substance, the protein, right? And there's the dose and there's the frequency. Okay. So I do all of my nutrition like I do a prescription. It's very precise and there's no guesswork. You don't want, and it's not the patient's job to guess. That's not the patient's job. It's my job to be clear and give the correct information, then to help the patient comply with it.
Yeah. So you're prescribing the macronutrients in this person's diet, and are you giving them a certain, basically eat this much polyphenol-rich vegetables and this much grass-fed beef? Is that what you're doing, or are you saying
I
just
don't specifically,
eat what you want?
I don't know. I never say do what you want. that never happens. Never. I pretty much tell them how much protein. So for me, it's 25 to 30 grams of whole animal protein per meal. Okay. And that's a cooked weight. So it translates to about 4, depending on the patient, 4 to 6 ounces, a bit more with fish because it's not as protein dense, right? And I don't necessarily say it has to be grass-fed beef, and because that's going to be very dependent on what the patient can afford and also personal tastes, right? Cultural preferences and things like that. But I make sure it's whole animal protein. I do not use plant proteins at all in my approach. And people are often shocked, why not, and so forth. The reason is that I want to make sure that I can get adequate bioavailability and absorption. And even with animal protein, it is hard. So with plant protein, forget about it. And with grains, there's a lot of phytates that will basically absorb the nutrients, like the minerals. And so the patient then gets micronutrient deficiencies. So yeah, I don't even play around. I feel like when it comes to preserving muscle, it's important to make sure my patient has the best shot at it. And nutritionally, I want to make sure that protein has the best shot at helping them at least maintain muscle. And I just want to point out too, I was a vegetarian for 18 years. So I pretty much existed on yogurt and eggs, and some cheese, So that's not to say you can't be vegetarian, but vegan is definitely not going to be, healthy enough.
Okay.
Yeah.
So you're prescribing animal-based proteins, you're avoiding plant proteins, and you're avoiding grains in your dietary prescriptions, essentially. Is that right?
Yes. I don't make them stick to a carb count only because I don't want them to spend all day calculating. Okay. Because what I find is that they'll do it for a while and then it drops off. So basically, I just give them, this is what you eat for the protein, and then we select the proteins that they are comfortable with. And then I give them the list of vegetables and I try to minimize or avoid the starchy vegetables. Okay. And then there is minimal fruit and 0 processed carbs if possible. So I try to keep away from the processed foods, obviously. And then making sure that they also get in their fluids. That's important as well.
Yeah. And what about fats? Where are you
healthy
on fats?
Healthy fats. So I like using the olive oil and avocado, things like that. And people always worry with me. I don't know why. They're like, oh, my chicken, I should remove the skin. And I'm like, that's the yummiest part. Why are you removing it? Chow down, right? And they always, I think, when I have dinner with people, I think they are aware that I do this kind of work, that I'm an obesity medicine physician too. And so they're all very self-conscious. And they're like, you're eating the skin? And I'm like, yeah, why wouldn't I? That's the yummy part, right? So no, I don't avoid the fat. And I think that helps with satiety as well. Most times when people have a good, decent meal, you eat eggs, for example. And, if you're doing eggs, like I was doing for X number of years, it's 4 to 6 eggs per meal. You will be full. I promise you will be full, and most times people don't want to eat anything else after that, right? So they're not grazing through the day, which is something that I think is a good habit to avoid any snacking or grazing. So I prescribe the meals and I often get, what about snacks? I'm like, what about them? Where can I fit in snacks? Now, most of my patients are eating 4 times a day, 4 meals, 4
Okay.
protein-rich meals, and a good proportion are eating 5 protein-rich meals, okay, spaced out. So when someone asks me about snacks, I say, what about them? Well, can I substitute? No. There's no substituting. We're having a meal. We're having nutrition and fuel, right? And at 5 meals a day, most people don't need or want a snack.
Okay. 4 or 5 meals a day?
It depends on the patient. The older they are, the more I push towards 5.
Okay.
And people are
Okay.
shocked that my patients that I'm seeing for obesity, that they are having 5 meals a day and losing weight. Okay.
Yeah.
And losing weight without compromising too much with their muscle mass. Okay. So
Yeah.
people are shocked and they go, how's that happening? And patients will tell me, how is this possible? So I had a patient and she had lost a good amount of weight in the first 3 months of my program. And then she went on to do the next 3 months, right? So at the next 3 months, I looked and I realized that, okay, I don't want her to lose too much mass. Okay. So she was going through week by week and weighing in. And she said to me, Dr. Loh, it's not working now. It was working great the first 3 months. I lost a lot of weight, but now it's not working. What should I do? And at that time, she was on 4 meals a day. And I said, we're going to add a meal. And she almost flipped out. She's like, add a meal. I just told you I'm not losing weight. And you're telling me to, I was like, look, you've been with me this 3 months, right? And you followed just what I said. You did great. Just trust me on this, right? She's like, okay. But she gave me that side eye. I know she gave me that side eye, right? But she did it. She did everything I told her to do. At the end of the second 3 months, so now 6 months out, she only lost 5 pounds. Okay. But when we did her DEXA, she had lost most of it in fat. And she actually gained a little bit of lean mass. She gained some muscle. She felt different. Clothes were different. Everything. And she felt great. And she was so exuberant. And she said, oh my God, I cannot believe that you added a meal and I got this kind of result, right? Because people are very resistant. They're trying. Most people I see with obesity are actually under eating. And that's something that we don't often talk about. A lot of times they are under eating, especially their nutrients, and they are malnourished in many ways.
Yeah. I think that's very common and that's missed on basic medical exams. They say, for instance, if you prescribe someone a GLP-1, they just stop eating. They stop eating in the same quantity, and now they're already in a malnourished state.
Yep.
Now they're just eating less of the wrong thing, and it just perpetuates this cycle of undernourishment.
Yes.
But okay, so let's say, so we've kind of got a good idea of how you do your nourishment prescription. What about movement and the other lifestyle factors?
Yeah, so obviously I am very much for resistance training, but with a mixed population, you have the elderly, I have people who are just recovering from hip surgery or need a replacement, so they can't weight bear the same way. So I try to modify things. A lot of times I will use isometrics. I think it is so underused in building strength. So the isometrics are great because it's very safe because there's no movement. So you are not going to hurt any joint because you're not moving, right? And that is working against a resistance, like pushing against a wall, for example. You're not moving anything. You're not going anywhere. The wall isn't going anywhere, but you are actually straining and loading that muscle. So that's an isometric contraction. And so for my patients who are chair-bound, bed-bound, a lot of times I will use isometrics. And then I also use eccentrics, especially for those who are new to exercise. So that's the lengthening phase. So if we do a biceps curl, right, lifting the weight is going to be the concentric phase. But when I lower the weight down again, that's the eccentric phase. That usually is the easier phase in terms of sensation, right, and effort. So if you slow that down, eccentric contractions are very helpful in helping you build muscle. So I like to use those tricks, and I start small. And sometimes, most people are very, very prone to doing cardio. They want to get on the treadmill, they want to get on the bike, but they don't want to do resistance training. So sometimes I try to work around. So if someone will get on a stair climber, I ask that they crank up that resistance. or if they're on their stationary bike, crank up the resistance so that at least your legs are working, steadily, consistently against a load. So we can start there and then slowly build them up. There are many ways to make it fun and to make it doable for everyone. I think we just have to be more creative when it comes to different patient population.
Right. And so with the high protein intake that you're prescribing and this isometric and gradual increases in loading with these exercises that you're talking about, people are not losing mass and muscle
No,
mass during their weight loss journey.
that's right. And that's the
Okay.
most gratifying thing. And now I have my own DEXA machine. So I could pop them in the DEXA, right? And there's very low, almost zero radiation, really. So you can
Yeah.
even do body composition on babies, which they have done. And so really, there's no contraindication. I mean, technically, if they're pregnant, but I didn't have patients who were pregnant come and see me actively, right? So most of my patients, I can just pop into the DEXA and check their mass, and especially check for, it's interesting, any casted patients, if they had a leg cast or something, ankle cast, right? And we would DEX them, and you would see literally over a couple of weeks, 3 weeks, you can see the mass go down compared to the other leg. So dramatic, right? And so just any kind of decrease in movement, in loading will result in loss of mass, especially as you
Yep.
age. So and having the DEXA was very, very motivating for the patient because they can actually see it. They go, oh my God, and they can see the numbers, but they can visually even in some cases see, oh my God, my left leg is smaller than my right, That's just a reminder, and it's very motivating for them to go on and do their resistance training.
Right. So the DEXA scan is basically like a low dose radiation that
X-ray,
can
yeah.
tell you body composition. Yeah, it's an X-ray, that can tell you body composition. Most people know it by having a bone density
Yes.
scan to see what their bone density is, but you can use it to look at fat composition, muscle composition, bone. And this is something that you can get objective data and track people as they go through their healing journey. Is that right?
Yeah, absolutely. So it is not covered by insurance. So bone density, depending on the population, insurance may cover it. Body composition, DEXAs, by and large, are not going to be covered by insurance. But over time, it has become more and more affordable. So you can find some commercial places that will do these DEXA scans. Now, there's some limitations to that. So for me, because my focus is on metabolic health and my expertise is on body composition, I don't like how they report the visceral fat because they report it in poundage. And what we need to see clinically, right, to correlate to risk, what we need to see is actually the visceral adipose tissue area between L3, L4, okay? Between, the spinal levels,
The third
L3,
and the
L4.
fourth lumbar vertebrae,
Yeah. And without that, just a number of like 6 pounds of visceral fat, it doesn't mean anything to me. Clinically, I don't know what to do with that. So all the commercial DEXAs report it that way, but they will report the muscle mass in terms of how much mass, the actual weight. And that can be helpful if you're tracking your mass.
Yeah. Okay. And because I think that's very interesting. If you look at most weight loss programs, there is a certain amount of muscle loss that happens when you lose weight. What is really striking to me, and maybe this is something you can comment on, because I know you're actually writing a book on this, is that with GLP-1s, which are the biggest craze for weight loss right now, about 40% of the weight that you lose is actually muscle mass.
Lean mass, yes.
And so now this organ that's keeping you metabolically healthy is rapidly being lost. And actually, in my practice, I've seen elderly patients go on GLP-1 agonists and were totally destroyed, essentially. I mean, they became so sarcopenic, which is this rapid loss of muscle, and cachectic, which is, frailty, that they were not able to thrive anymore because of a GLP-1 agonist. Now, that's not an argument against GLP-1s, but I'm curious what your thought is on this, because you're doing this weight loss and metabolic health program that's preserving and even increasing muscle, whereas a lot of patients are tackling this from a totally different approach with a pharmaceutical.
Yes. And I will say, to be fair, with GLP-1s or with medication approach or even diet and lifestyle generally, and with weight loss surgery, you do see about anywhere 30 to, it's been reported up to 50, sometimes even 60%, depending on the patient population, of lean mass loss. So it's not unique to the GLP-1s themselves. And just even dieting on your own or even under supervision, but not maybe informed supervision, right? That you could have that. But the GLP-1s are actually very potent in terms of how they override your appetite. And a lot of people believe that they actually act in the gut. Actually, the main action is in the brain, in the feeding centers of the brain, and they intersect with immune circuits in the brain. So in one sense, it will directly affect your feeding patterns and make you not want to eat. But since it also intersects with the immune circuit, it intersects with the circuit that brings on sickness behaviors. So when you're sick, and I had the flu earlier this year, right? I didn't want to eat. I didn't want to drink. I didn't want to move. I kind of felt down, right? That is what we term sickness behaviors. And a big part of it is not wanting to eat. Most of us remember when we're sick and we're like, I don't have an appetite, right? So part of that not wanting to eat also comes from sickness behavior. And it has profound implications in terms of the rest of the hormones in your body, because there's usually a synchronized effort. It's a system, right? And GLP-1 exists within this system of hormones. What you did was take one hormone within a system and ram it down your throat. You explode the signal and you blast it. Okay. And you drown out other signals. And now what you've done is distort the architecture in your body. Okay. So this can prompt profound anorexia, not wanting to eat, and you're not getting enough intake. The other thing that is interesting about GLP-1 is that GLP-1 causes you to release interleukin-6, which is an inflammatory molecule. It's a signaling molecule. Talked about the link with the immune system. This signal is going to direct your stem cells in the fat, what we call the pre-adipocytes. It's going to direct them to become brown fat. And brown fat is a specific type of fat that actually burns a lot of calories to make heat. Okay. And so a lot of people put themselves through like cryotherapy, or they go for cold swims or cold baths, or they stand out in the cold because they're trying to make their body make more brown fat so that they can just, produce more heat and lose weight that way, use up calories that way. Now, what people don't understand is that cachexia, which is profound muscle loss, people think there's a muscle problem. People studying cachexia, whether it's in pharmaceutical circles or in research circles, they are studying the muscle cells. But we also know that in most cases, of cachexia, there is increased browning. In cancer, for example, 20% of cancer patients die from the wasting or the cachexia alone. They're not dying from the cancer. They're not dying from the treatment, just the wasting that comes about with the cancer, right? Now, that wasting is often associated with increased browning. And so now we have brown fat activation all over the body, and you keep wasting all those calories in terms of heat, so that no matter, their appetite goes down, but even if you slam them with nutrition, they actually cannot keep up, because they're just wasting away this heat. So because GLP-1 medications do promote browning, it's not the main effect for weight loss. But in the population that you described, the elderly, they're already compromised. They're maybe more frail already, right? Those are the ones I worry about, because the minute we activate that and they get into a cachectic profile, a wasting profile, it's very hard to turn off. Okay.
Right.
And they have profound wasting. So that's just one way that might be having the effect. Okay. And so, yeah, I think that we are so focused on weight, we don't think about what we're losing. Okay.
Right.
And what we're losing is more important than just a number of how many pounds we're losing. But that discussion, it still doesn't get discussed very much.
Yeah.
If you look at criteria for keeping someone on the medication, it's how much you lost, right? It's a number on the scale.
Right.
Nobody's talking about, hey, maybe she's losing a lot of weight, but actually a lot of muscle, because I see her really getting weak and frail, and, we should be stopping, or at least like, hey, going down on dose or something. But
Right.
no, we're going by only the number. It's working. She's losing weight, right?
Mm-hmm.
And you could be doing more harm than good. But here, I'm going to bring something else on board. So let's say you took this patient and they came to you, they had some obesity and diabetes, right? And the doctor says, okay, you know what? You should start on a GLP-1. Okay, because they came to you and now the A1C was 9 or 10 or something like that. And you think it's a great idea. You start them, they lose weight, the blood sugar gets under control. Rah, everybody is so happy. Okay. And then they keep this patient on. Okay. And let's say it's a 58-year-old, 55-year-old, doesn't matter. 10 years later, because now they're talking about keeping these people on these medications forever, right? So
Right.
10
Yeah.
years later, the patient comes in and you do, their usual panel of labs. And now the A1C is, wait a minute, it was 5.4 and now it's 7.8. Let's just say, okay? The patient swears, I'm not doing anything different. I eat the same. I'm still doing my exercises, but the muscle mass has shrunk.
Right.
Okay. And so we started with obesity and diabetes. And 10 years later, we have sarcopenia and diabetes. I don't know what we did for the patient, but that is not a conversation that we are having because no one thinks that far.
Yeah. So let's talk a little bit more about that brown fat hypothesis that you have. These GLP-1s are causing a release of interleukin 6, which is converting white fat to brown fat. And brown fat is highly metabolically active and heat producing. It's a lot of kids.
Yeah. It is not a hypothesis because there's a paper, Gutierrez in 2022 actually showed this, and they showed that the anti-diabetic effects of liraglutide, which is a GLP-1, if they
Mhm.
block the interleukin 6, you didn't have the anti-diabetic effects. So
Okay.
we know that it is actually using that circuit and that there is a browning effect. We see that in agents, in weight loss agents like GLP-1 and glucagon, when they add the glucagon on board too. That's through a different mechanism, but we also see it with the agents that add on glucagon. So we actually know this, but
Okay, so
nobody
that's
links
very
it.
cool, actually.
Yeah.
Yeah, it's very, and no one talks about it, right? I mean, I just did a whole episode on GLP-1 and I didn't come across this browning of white fat, which normally we would think, hey, that's a good thing. You're creating more energy, metabolically hungry tissue in your body, burn more calories, lose weight. But like you talked about, there's a certain contingent of the population who can't afford to have this metabolically hungry tissue sucking away their nutrients while they're trying to thrive and be metabolically healthy.
100%. So number one, let's say you have a 50-year-old healthy. She put on the GLP-1, she lost weight and great, and everybody's rah-rah. And then she gets a diagnosis of breast cancer. If it were me, I'd look at that GLP-1 and say, you know what, let's have a discussion. I am worried at this point. Now, you're a surgeon. So someone in the hospital for surgery, post-surgery, wound healing, right? Any hospitalized patient. This came up in the Q&A, and I did that talk at the obesity conference just last weekend. Oh, what happens if a patient gets sick? Yeah, I would, at the very least, decrease the dose. If they are hospitalized, I would stop. Because by definition, if you are sick enough, especially these days, to be admitted to the hospital, you're pretty sick, right? And you're also more sedentary. You're going to have, be bedbound more. And so you're at risk for muscle loss, very high risk. And you're in a catabolic state post-surgery and or during illness. Yeah. So these are the states that I would be like, yeah, I think we should stop that. Right. But that
Right.
never gets discussed either. So, and a lot of clinicians, a lot of doctors were asking me, oh, we never thought about that. So again, we're so eager to jump on board, oh, yay, look, but it's losing weight. Yeah, it's helping. But what are we actually doing? Nobody stops to think. And it's, we had this discussion too, right? We work, unfortunately, in a system that doesn't prioritize or reward thinking.
Or creativity.
Yeah.
Or deeper understanding. Yeah. I mean, it's what's on the glossy pamphlet that you're handed to in the clinic,
Yeah.
That's what the world essentially wants us as doctors to know. So let me ask you this, and I'll just add here, I stop GLP-1s on all my patients before I operate on them. Actually, 3 days before I do an operation,
Excellent.
I stop their GLP-1s. And the reasons are a couple fold. One is they all cause gastroparesis.
Yes.
So your stomach doesn't empty. Yeah. And After surgery, before surgery, during anesthesia, these aspiration events can happen where people are not emptying their stomach. They're maybe sedated or they're taking pain meds and the stuff comes up. And if you aspirate it into your lungs, it is a bad day and a bad week and can even be fatal in some circumstances. So I do it in that situation. Also, I need people to be in anabolic mode after surgery. I need
Yes,
them
that's
to
exactly
rebuild
right.
tissue. And these GLP-1s they're blocking that essentially. They're sending people down the road of catabolism, which is, towards cachexia and sarcopenia. So they're definitely, if you're going to have a surgery and you're on a GLP-1, talk to your doctor about stopping it before you have the surgery and how long to be off of it. Tell me about this immunological, neurological pattern that GLP-1s stimulate. That's something that's new to me.
So we've known for a long time that when you have a rise of interleukin-6 in your body, that actually is going to bring about a rise in GLP-1. So the interleukin-6 directly stimulates colonic cells and the areas of the brain to produce more GLP-1. The flip can happen that when you have high GLP-1, you're going to stimulate the immune cells to produce IL-6. So there is a clear link and crosstalk between the metabolic system and the immune system. Now, I put this in my book and I said this at my lecture at the conference. This is something I want people to understand. And a metabolic intervention is always an immune intervention. An immune intervention is always a metabolic intervention. Why? Because we need energy. Okay? I just kind of had randomly brought up this example, but recent events have highlighted it. When there is any conflict or war or excursions that happen in the world, armies need what? Supplies, resources, energy. So without that, there's no defense, correct? So your immune cells, if they are ramping up for defense against a germ, a bacteria, or they're trying to deal with some area of damage in your body, they're going to need energy. So what happens, and a lot of times people misunderstand insulin resistance. Insulin resistance is a normal physiologic adaptation. I have this in my book and I said this and it kind of like, a lot of people were like, what? Because look, when you get sick, all right, what happens is you become naturally insulin resistant, which means that your GLUT4 tissues, your muscle and your fat are not going to take in the glucose as well or as easily. And so since they're not taking in the glucose, there's more glucose floating around in the bloodstream. For what? For your immune cells, for the brain, for the liver, to make all the, inflammatory proteins and so forth, signaling proteins and so forth. We have to find a way to divert energy. You understand? That's why metabolism is so fascinating to me. And my main interest is in immunometabolism because I don't see a separation. Okay. So now, if we need to defend against something or against either a pathogen or damage in our body, right? Then you're going to have to give those cells the energy and you're going to have to shut off the divert from muscle and fat and say, guys, sorry, we're closed for today. We got to get all this to the immune cells. We got to get this to the brain. We got to get this to the liver. Okay. So we think of insulin resistance as a bad thing that we have to work against. This is a signal from your body trying to adapt to changing circumstances. Again, to our point earlier, to changes in the environment that are not natural for us. And our body says, oh, this is causing a lot of damage and our immune cells need to work harder and we got to give them energy and we're insulin resistant. And we're like, it's bad. It's genetic, right? It's because you're aging. And nobody understands this is pure basic physiology. And it's your body keeping you alive and doing the best it can. Okay.
Yeah.
Now, another naturally insulin resistant state is when you're pregnant. Pregnancy is the same. You want to prioritize nutrients for the fetus, the growing fetus, right? So again, this is not like, oh, what happened here? The bad guy showed up suddenly. No, this is an adaptive response. And over time, if we keep pushing the system, then the level at which the system can adapt and respond, becomes less and less. And then we topple over into disease state.
That concept of basically any energy preservation in the setting of stress, I mean, we see it all across the board. So, I mean, if you're psychologically stressed at work, if you're sleep deprived, if you're
That's
injured,
sleep.
I
Sleep
mean,
is big. It's not a little
yeah.
thing. It's a huge thing.
And we've shown this. I mean, this is clinically evident that insulin resistance is high, blood glucose is high during these periods of stress. And let me ask you this, is taking a GLP-1 agonist putting you in a state of stress?
So it does definitely change the immune tone in your body. The problem is we don't quite know a lot about how it changes the immune tone because guess what? We didn't bother to study it. In fact, most people don't even know about this connection. So why would they even study something they don't know about, right? But what we do know is that it definitely changes the immune tone. And the main thing I want to point out here and that I pointed out in my lecture and in the book, I think most people think of inflammation as a bad thing, and anti-inflammation is the antidote, right? So the bad guy is
Mhm.
inflammation, anti-inflammatory is the good guy. And if you see a high inflammatory number in interleukin 6, which is a marker for inflammation, then that's bad. And if we get that number lower, that's good. Okay, that is way too simplistic. And it's because something like interleukin 6 has different signaling modes. There is an inflammatory mode and there is a homeostatic, quote unquote, anti-inflammatory mode. So let's say you just did surgery on someone and that wound is still fresh, right? So there's an inflammation process going on around the wound and the tissues that you just worked around. Okay. Over time, though, as the wound starts to heal, you may still have high levels of, let's say, interleukin 6 or other cytokines, but it changes its signaling pattern. And now we turn on the repair mode. You are going to need that part of inflammation to repair the tissue. Wound healing will not happen without your immune system turning on that repair system. So your immune system does a lot of things. It's not just bad or good. It has a range of roles that are dependent on context and the tissue and timing, right?
Mhm.
So now we know that we changed the tone with the GLP-1, the immune tone. We don't quite know how, right? What we do is we have a very big consistent signal because we slam in this GLP-1 signal and it's very loud and it's consistent. Now, the way our body produces GLP-1, it's very short and it's pulsed and it works with
Mhm.
the other hormones. We've taken all of that away. We just have one very loud signal on all the time. And we're definitely changing the immune tone, which actually in a normal human being changes over time and adapts to different conditions. Now we kind of flatten everything and hard lock everything. So your level of adaptability is actually going to be dampened as well, right?
Yeah.
And this is what we're not talking about. And this is what we need to have more research on, but you want to bet that we're not going to. I put money on the fact that we would never touch
No.
that with a
Yeah.
9-foot pole, you know?
No, I mean, if there was some money to be made off of
Yeah.
it, maybe, but I think the results only would drive us towards less GLP-1 usage, honestly, and it's already a multi-billion-dollar industry, so that's probably not gonna happen. This concept of inflammation being bad, that's something I talk about all the time as well. I mean, inflammation is necessary for life. I mean, every minute of every day, you are developing micro injuries, little stresses that need repair. Inflammation is the repair process of your body. And so it mobilizes the immune system and the nutrients that are needed for repair. And without inflammation, you would fall apart. So what needs to happen is inflammation has to be turned on and then turned off. But we find ourselves in this state of perpetual inflammation due to diet and lifestyle choices, environmental toxins, and that ends up what takes us down is this perpetual inflammation. But inflammation is necessary for life.
Inflammation dial needs to switch from repair mode to attack mode to defense mode, right? For example, if you were anti-inflammatory all the time, you're more predisposed to cancer, right? You need your immune system for tumor surveillance. So at night, actually,
Yeah.
we have a little bit more inflammatory action at night. Okay. And that's because that's when those killer T cells are out there and they're looking for these cancer cells. All of us have cancer cells in our bodies at any point in time. And the fact that you're not sick from cancer is because of how well your immune system is being activated to get rid of those cells, right?
Yeah.
If you switch that off, right, and you eradicate that, then, you lose your tumor surveillance, for example. In
Yeah.
fact, in cancer, what they're finding is that the T cells, for example, are not as aggressive. They're really not very inflammatory.
Yeah.
They're just sitting around and they let the cancer cells walk all over them. And all the therapies that they're trying to develop is to wake up that more aggressive side of the T cells, right? And other immune cells.
No, that was something I researched during my residency, was how glioblastoma, which is a cancer in the brain, actually mobilizes the immune system to suppress it through these myeloid-derived suppressor cells. There's a certain part of the immune system, like you said, it turns it off, it turns it on, it goes into defense, offense, and cancer develops these strategies to, one, evade the immune system, which is its biggest enemy, and to use the arm of the immune system that churns it off to its advantage.
Like the
And
Borg.
you're right.
If you're a Trekkie fan.
And there's these checkpoint inhibitor drugs now that basically are being used to try to churn off that suppressive side of the immune system. And then in combination with vaccines, get the immune system to kill cancer. Because I'm telling you right now, the chemotherapy and radiation we use right now, someday we'll look back on that and say, how barbaric.
Yeah.
Oh, and surgery too. I mean, I do surgery on brain tumors all the time. And they'll look back on that and they'll say,
my God, back in the cave
I can't believe
days.
they cut open their head and they cut out these tumors, and they'll think, what barbarians? Because now we just tell the immune system what to do, and it goes and removes the cancer cell by cell until it's all gone and there's no residual carnage. And anyway, that's something someday we'll see.
Again, this is all happening, very exciting at the research level in the bench and translated a lot of times in therapeutics and pharma and stuff like that. I think the sad thing is it doesn't get to mainstream medicine, and, I just feel like in terms of the medical curriculum, we're like 40, 50 years behind. What they teach today is what they taught 40, 50 years ago, by and large.
The world doesn't like change.
Right.
Change stresses the mind, especially for people who are already stuck in ruts of dogma, which is very common in the medical community, honestly. So, Dr. Loh, what are you doing actively right now in your research and in your patient care that's kind of exciting you, or is something that people can look forward to?
So my book is coming out. It's called The Architecture of Enough: Hunger, GLP-1, and the Immune Metabolic System. So that's the book. And I've been giving talks. I'll be off to India next month to give a talk in Goa at the obesity conference there. So I'm very excited. The other thing that I do is metabolic health coaching. So I do that online. And I help people do all the things we talk about, get their nutrition in place, get their exercise, but with the best evidence-based knowledge, the latest science, and also practical ways to make sure that we can bring that knowledge into actual application in life. Specifically now, I've been focusing on people who started on GLP-1s or are trying to get off GLP-1s. So in that category, I'm sure you've noticed people who got on GLP-1s, they're struggling to get off if they want to get off. Many of them say, I don't want to be on this for life, doc. But whenever they try to wean down, the weight comes back up, they panic, they don't know what to do, and they get in a tizzy, and it's a very lonely place to be. So I do a 6-week coaching program to help them get that structure and wean in a very structured way. I don't handle the medications. I'm not their doctor, but I'm really augmenting the lifestyle part and giving them the knowledge base and the practical tips to be able to accomplish that. So that's the main thing that I've been working on these days. And obviously doing like you, sharing as much of this knowledge as possible to people who are open enough to listen, because not everyone is open enough.
Yeah, well, I think that's really cool. I really admire that you're out there stepping out of the mold that medicine tries to push us into, because it does. It tries to fit us all into a certain shape that sticks within that dogma that drives medicine. And I think it's really cool when you have the courage, you have the creativity, and you have the curiosity
Or
to
maybe,
ask you more
Dr.
questions and
Kumar,
step outside that.
maybe we're just fools, you and I both. I don't
Well,
know.
to some of our medical colleagues, we might be, but to my audience that's listening right now, they're very grateful. I guarantee that. So, how can people get a hold of you?
Well, they can, I'll just give out my email because I go through it. It's vlmdpodcast@gmail.com. On YouTube, I have a channel, Dr. Vyvyane Loh, and I'm on Instagram as well. So they can also message me there. But email
Okay.
is best, vlmdpodcast@gmail.com.
Okay, great. I'll put that in the show notes. And thank you so much for joining us. This was an awesome conversation.
It was a lot of fun for me. And it's always nice to have, a conversation with a kindred spirit. Really gets lonely out there on our own, right?
It is. All right. Cheers, Vivian. Thank you
Thank
so
you.
much.
Bye.
Okay, so I hope you enjoyed that conversation with Dr. Loh. She has a truly creative and curious approach to metabolic disease. I learned a lot of new things today, and I hope you did too. If anything in today's episode sparked something for you, whether it's rethinking your body composition, questioning what a GLP drug might be doing long term, or just starting to look at chronic disease different, I hope you take that curiosity and run with it. That is exactly what this show is for. You can find Dr. Loh at vlmdpodcast@gmail.com, on YouTube, and on Instagram. Links are in the show notes, and her new book, The Architecture of Enough, is also coming out soon. And based on today's conversation, I already know that it's going to be a must read for me. So until next time, stay curious, stay skeptical, and stay healthy. Cheers.